are going into the health realms because once you are taking care of the spirit, you also have to take care of the body, right? If you don't pay attention to it, you could find yourself in deep, deep trouble. And of course, the usual, I wanted to say suspect, right? But the usual guest, Dr. Kasum, is in studio, should help us do that. But before that, we want to hear from you. We want to hear all of your questions, your comments, your contributions, anything really that's boggling your mind. You can do so via WhatsApp line 0204-447-033, 0204-447-033. Alternatively, you could send in a tweet or a post via the X platform, formerly Twitter, using the hashtag Sunday Breakfast. Mention my handle at Mensa Duncan or Enos at Eno_S, and we'll be glad to read all of it across for you. Doc, welcome.
Thank you.
We are twinning. We are twinning with the whole double-breasted thing.
I didn't get the memo.
That's okay, and some other time. Doc, wow, interesting. We are discussing peptic ulcers.
Ulcer disease.
Wow.
Yeah.
Sounds like a very complicated, very technical area. So today we'll leave you to do a lot of the talking. But just give us a little overview. When we say peptic ulcers, what are we looking at?
Okay, so basically peptic ulcer disease are a group of diseases. So when we say ulcer, it's like a sore. So when you have a sore, but this time around the location of the sore is either in the stomach or it is found within the first part of the small intestine, which is the duodenum. So when you have an ulceration or when you have a breach in the lining of these two areas, then we say you have peptic ulcer disease. It's very important and very prevalent in the sense that, you know, as part of digestion, we all know from our basic sciences that the stomach, you have HCl or an acid being produced there. That helps with digestion. It helps to sanitize whatever food that you bring in. And then it also helps with some digestive processes and activating certain enzymes to help with the whole digestive process. So imagine this is happening within the stomach. Okay. And you need something to protect the soft lining as well. So usually there's another mechanism that helps to protect the lining, in as much as you're producing acid to help in digestion of whatever that comes in. You also need to protect whatever that is forming the stomach. Okay. You get it? So you need the we call it mucus, thick mucus lining that helps to protect the lining of the stomach as it is doing its work. But here's the case where when there is a breach in the lining of the stomach or the duodenum, as I mentioned, then there's a sore there. It means that there's a sore within the stomach or there's a sore within the duodenum. And this sore, it means that as food is coming in, the food can traumatize the sore. That's one. Also, the acid being produced to do the work can end up also further traumatizing this sore. You get it? And then eventually it becomes chronic. So it stays there, it can't heal. The environmental conditions within the stomach will not make it conducive for the sore to heal. So it can progress, become chronic, give whoever is experiencing it or the patient certain signs and symptoms that become chronic. And eventually it can, if it is not treated or the attention is not paid to it, it can end up giving you certain complications that are very life-threatening. So in a nutshell, that is what peptic ulcer is. So it's a breach, and usually as a result of imbalances between the protective mechanisms and the acid-producing mechanisms.
Wow. Yeah. So before you talk to us about the causes of some of these peptic ulcers, is there a difference between ulcer as we know it and peptic ulcer?
No, so peptic ulcer is just descriptive.
Of
So
Okay.
it's just
The
telling
location
you
in your
the
stomach.
location in the stomach. It's found within the stomach.
Or the
It's
small
found within the
intestine. That's
duodenum, the
the
first
duodenum.
part of the
Cool.
duodenum. So that is basically why it is called peptic
Peptic
ulcer. We
ulcer.
actually call it peptic ulcer disease or
Okay.
PUD.
All right, cool.
And usually it is caused by one of the main risk factors is H. pylori infection. So H. pylori is Helicobacter pylori infection. So it is a kind of microorganism. It's a gram-negative microorganism that is usually transmitted through an oral and oral routes. So when I say oral and oral routes, you understand. So when maybe
You kiss,
through kissing,
you use someone's
or even
toothbrush.
yes, or you use somebody's utensils together, close family, or it could be that you have your water or you have your food contaminated, so fecal-oral contamination as
Okay.
well, okay, or you have your so either your food is contaminated or your water is also contaminated from the Helicobacter pylori that we are talking about. So this Helicobacter pylori, most of the ulcers have been implicated. It's been implicated in most of these ulcers. And it needs to be treated. Once you have been diagnosed of peptic ulcer disease, the first thing is to check if it has Helicobacter pylori in there. So once you check and it's there, then it means that you would have to treat it and eradicate it. Otherwise, if you do not eradicate it, it means that it's going to persist, and then the management is going to be very difficult. So that is one. And then also, there's something that, as I mentioned earlier, I said that we are looking at the protective as against the destructive mechanisms. So the protective mechanism, one of them is the mucus, or the thick mucus that helps line the stomach or the other areas. So if you have anything that you are taking in that affects this protection, so something like drugs, like we always say brufen, or NSAIDs,
I hear that
you
a
know,
lot.
so NSAIDs or diclofenac, all these things, the non-selective, non-steroidal anti-inflammatory drugs tend to cause, destruction in the production of these protective or mucous lining. Okay, that's another way. So if you are taking these NSAIDs indiscriminately, then you are also prone to getting these peptic ulcer diseases, because the medicine is going to just drop directly on the lining, on the mucous lining, and then it can cause an erosion on the lining, and then eventually continue the whole process. And if you have a superimposed infection of the H. pylori, that can also end up giving you this PUD. Another modifiable factor could be you taking excessive alcohol intake. So our alcohol has resurfaced here.
It has reared its ugly head.
In this studio
Exactly.
will not like that.
So taking in a lot of alcohol as well on an empty stomach also will predispose you to getting ulcers. And there are times too that stress conditions, so maybe you are going to undergo some surgery somewhere and all of that, that can also predispose you to getting some of these gastritis and then ulcers. And the most important thing that we need to be able to tell is that the two common sites that I have mentioned is either is gastric, is within the stomach, or is within the small intestine, which is duodenum. So both of them, actually, you would have certain signs and symptoms that are peculiar to them in terms of pain. They would all come with pain. Pain that is epigastrium, above or around above the navel. Okay, so just around that area, you may feel some pain. And the pain is usually gnawing. So it's like, it's graded. It comes, it's grading, then gets to the peak, then it releases like that. So we call it gnawing pain. Now, for you to be able to tell whether it's gastric or duodenal, there are certain key features that you look out for. So usually for gastric, these patients will tell you that I tend to have pain more when I eat. It becomes worse when I eat. And the reason is that when the food gets into the stomach, you need something, controlled contractions and relaxations, which we call peristalsis. So once there's this contraction and relaxation, and imagine you have a sore in that area with the food within that sac. So the contractions and the relaxations will rather make the pain worse when you eat.
Okay.
So they tend to be very scared of eating because it's a nightmare. Once I eat, that's when I feel the pain most.
Wow.
So such patients would rather not eat. So they end up losing a lot of weight. So you would see that they would have lost a lot of weight. Or they may end up inducing vomiting right after eating.
Wow.
You get it? As opposed to the duodenal ulcers. The duodenal ulcers, actually, they tend to have relief after eating because the food now, it helps reduce the acid that is going to go through the small intestine. So then they tend to have relief anytime they eat. So for them, they tend to eat more and they end up gaining more weight compared to the gastric ones. And usually the duodenal ones are commoner, especially with younger people. And then the gastric ones, the age range is rather with people who are a little middle age and then older. You get it? So aside the pain that they may present with, the other thing that they may present with would be that they may be vomiting, nauseous, vomiting, bloating, all of these are little
So these
signs.
are symptoms of peptic
ulcer disease.
Growing up, we were told that if you don't eat, like, you get ulcer. It was like such a common refrain, right? Eat or you get ulcer. Is it really the case? I know you've explained, to an large extent, it's also psychological, right? For those who eat or the fear of eating complicating the situation. But is it really the case that the onslaught, for want of a better word, of these ulcers you are talking about, peptic ulcer, is because in the very, very initial stages, whoever is suffering from it was not eating?
Yes, so prolonged starving is another way of causing. So if there's prolonged starving, it means that the acid that is produced, and there's maybe a reduced production of the mucous membrane that will help protect the lining. If you have that reduced levels and then you have a lot of produced acids, you tend to offset the balance.
Okay.
And that can end up giving you the ulcer.
Are there certain
As opposed
foods that, like milk, cold water, pepper, that, if you have, you should stay away from? Or that could probably lead to you getting ulcers?
If you do have ulcer, obviously you want to stay away from alcohol because it will make the erosion worse.
Okay.
You would want to stay away from anything spicy because it will make it worse for you as well. You would want to stay away from citric containing foods like orange juices, pineapple juice, all of those. And then rather you would want to take in a lot of milk containing products.
Oh, really?
Because it's alkaline.
Wow.
So it will help neutralize.
I thought it was
acid.
the opposite. Wow.
No.
Look at me learning so much. As though you're in a medical class. Anyway, Doc, some questions are coming, so we want you to just do justice to them for us. But if you're wondering how you can send in any of the messages, you can do so via our WhatsApp line 0204 447 0333 0204 447 033. Alternatively, use the hashtag Sunday Breakfast. I will be glad to read all of your message for you. This one says, aside causing pain, can peptic ulcer disease cause someone to eat frequently? I think you touched on that.
Yes, I mentioned that.
Yes, as in
The
cause intense
duodenal,
hunger.
Yes.
Wow.
So the duodenal one, most of the time, because when you eat, you get the relief. So you tend to binge eat. So anytime there is pain, you want to find something to eat.
Wow.
Because it helps.
Wow. Is it more
relieve the pain.
psychological?
No, it's not psychological. It's the pathophysiology of the whole disease.
Oh,
It's
okay.
because once acid is being produced, and there's nothing in the stomach for the acid to act on, it will proceed to the first part of the small intestine. And that would end up causing more erosion or more pain on the ulcer that is there. You get it? But once you eat, then the acid gets the food to be able to act on.
Okay.
And then the food that has been acted on can now proceed to the duodenum.
Wow.
And then you end up not having
Sounds
that
very
pain.
complicated.
Well, not so complicated, but I mean, once you understand the physiology, it's
Well, I think for lay people like Anna and myself, it's a lot going on. Right? It's a lot going on.
So when you come to the hospital and you have peptic ulcer, what can be done for you?
For you,
Yeah.
okay. So usually we would want to investigate and be sure because there are a lot of people who come, hey, me or ulcer.
Self-diagnosed,
you know.
Because they're not eating properly for like 2 or 3 days, then they just diagnose themselves.
Exactly. You get it, but it needs to be properly diagnosed.
Yeah.
And the gold standard is to do the upper GI endoscopy. So the upper GI endoscopy is passing a little flexible tube through your mouth.
Oh, Lord.
It goes down.
Oh, Lord.
And then you can visualize it.
Oh,
so you can
Lord.
visualize. I know it's uncomfortable, but it is actually very
Efficient.
diagnostic.
Okay.
Okay. So then it goes down, and then you're able to visualize from your esophagus all the way to the stomach. Then it goes to the intestines as well. So there'll be a camera where the operator would be able to tell and see wherever the ulcer is. So you can visualize it directly. And then anytime you find any suspicious area, so like an ulcer, you would want to take a piece of it. So you pass a little forceps and then take a little piece of it. So this piece we call a tissue biopsy. So you take this tissue biopsy and then you run 2 tests on it. The first test is to check if the H. pylori that we spoke about earlier is present. So we call it a CLO test.
Okay.
So you check that. That is about a 5-minute test where you put it on the small specimen and then you are able to detect whether it's CLO positive or CLO negative. That helps to direct your management. And then also you can take, if it's suspicious enough and you are thinking that it may have transformed to something else, one of the complications, becoming a cancer of some sort, then you would want to take that for histopathological examination, where it will be checked under the microscope for any malignant transformations.
Wow.
So the endoscopy is very, very important. The less invasive tests could also be that you can be asked to submit stool tests, stool sample for the H. pylori to be checked, whether it's present or not. But that test usually would give you a lot of false positives. You get it? So it's not as sensitive as the endoscopy. Another test could be that you can do a urea breath test, where you'll be given something to take in, and then because the H. pylori usually has something we call urease. It's an enzyme that can break down urea. So if you are given some meal that contains urea, it's able to break it down, and then you can collect that breath and then analyze for any urea content. And that can also give you an indication of whether you have the H. pylori or you don't have the H. pylori. But as I said, the gold standard is the upper GI endoscopy, which helps you to see as well as test for that. So once you have gone through this testing and your CLO test is positive, then there are 2 ways of managing. So usually you do the medical management, where you'll be given some antibiotics, a combination of antibiotics, and for 2 weeks. So usually we give amoxicillin and then clarithromycin in combination with other medications, which we call either the proton pump inhibitors or H2 receptor blockers.
Okay.
So the last 2 medications I mentioned are just going to reduce the acid production within the stomach, so that the antibiotics can act and then help take care of the infection. And then after that, you need to be on these proton pump inhibitors or the PPIs for a period of about 6 weeks. So that will help reduce the acid production so that the ulcer or the sore can heal. You get it? Then afterwards, all right.
There are some questions I want you to just briefly deal with because time on us. I say, good morning. My name is Rosie. Actually, Rosie Baba from Mandari says, I'm salivating too much and they said it's ulcer. Is salivating to one of the signs, and how can I stop it if there's any advice? This one also says from Oscar Opak from Itibieku says, what's the first thing to do when your ulcer gets triggered at midnight when there's no health facility close to you? Wow. Call your MP and
MP, really?
Yeah, call your MP and let him put a motion in parliament. Why is there no health facility near me? Anyway, doc.
All right, so I'll start with the last one. So if you've been diagnosed that you have ulcer, then it means that you have to have it treated. You don't need to wait for it to be triggered at such hours that you can't do anything about it. But most of the time, if he's talking about it being triggered at night, then it's likely it's a duodenal ulcer. Okay. So you can look for some milk and then drink. Just
what kind of milk is it?
So even the evaporated, yes, you should be able to find some relief. It's alkaline, so you should be able to neutralize the acid that is being produced. But you need to quickly go to the hospital and have it treated. Because I need to emphasize this, because if long-standing ulcers that are not treated have very, very serious complications.
Oh, wow.
So some of the complications can be perforation. So the ulcer will continue to be eating away, and then it will perforate. Once it perforates, you notice that now the gastric contents would then enter a sac, the sac within our body, the core of our body.
Yeah.
Okay, once it enters that sterile area, then it becomes an emergency and you have to be operated on to close that perforation. Another could be that it can lead to, if it is eroding, its path of erosion, if it gets to a blood vessel, it can end up puncturing a blood vessel. And if it's an artery...
That sounds very fatal.
Yes. If it's an artery, imagine you are going to be pouring blood into your stomach.
Oh, Lord.
Imagine if this... Yes, and imagine if this happens at home and you don't... And in this environment where you can't get yourself to a hospital in the next few minutes, it can be fatal.
Wow. So if it happens like that in that case, then surgery is needed. So
once you come in, it depends. If it is upper GI bleeding, you would have to do something we call nil per os. So nil per os, you would, nothing goes into the stomach. So you are not going to be taking in anything. We are going to give you everything through IV infusions. That's one. And the second thing is that we are going to give you high doses of what? PPIs, what's it called? The omeprazole that I mentioned, or the Nexiums. We are going to give you that very high doses to be able to reduce the acidic content within your stomach. And then we are going to replace the blood that you are losing. So all these emergency procedures are to help you stop bleeding, or to help reduce the bleeding.
The bleeding for you, interesting.
At a basal level. Once you are a little stable, because we can't take you in when you are bleeding. So once you are a little stable, then the other surgical techniques can take on. Like you going in again and then doing something we call sclerotherapy, where you go in and then inject the area.
We will continue this conversation as to go. Some people are sending messages and I just want us to help them. Okay. Khadija sends a message, but with this message, she's mentioning certain drugs. So I'm not sure we can mention down air. So maybe Khadija will have to reach out to you privately. Right. I don't know how she can do that.
Okay, so definitely, I think we can give her.
So, okay, so Khadija, yeah, she sent a picture of the medication. That's quite serious.
There was one question that salivating too much.
Yes. So salivating too much can be one of many things.
And look, to that question, add whether it allows you to visit the washroom, the restroom regularly. That's if you have peptic
ulcer disease.
Then we can call it a wrap.
All right. So for the salivating, I wouldn't say that it's classical of peptic ulcer diseases. It could be so many other things. It could be some drugs that you are taking that is causing sialorrhea or drooling. Okay. It can even be some blockade somewhere. So you have to visit the health facility, and then we have to check that out, and then properly diagnose what is going on with that. And then in terms of you having free bowels, yes, there are some people who end up having free bowels when they have PUD.
Peptic ulcer disease. Doc, thank you so much. Wow. There's also
so many messages.
Yeah, there's also someone asking, okay, this also sent a drag. See, maybe you have to consider this. Just maybe
all right,
then,
yes, hopefully next week.
So grateful for your time. But Khadija is on standby for you.
all right.
So grateful that you could join us today.
Right. Thank you so much. All right.